Moving on to our next speaker, Dr. Durgaprasad Reddy, Head of Cardiac Sciences, Vydehi Institute of Medical Sciences and Research Center, will be addressing us. He'll be speaking on the topic, Conduct of Cardiac Transplant. One of the most renowned cardiothoracic surgeons, Dr. Durgaprasad B. from Vydehi Hospital, has performed over 15,000 cardiac surgeries, as well as many successful heart and lung transplants in his 23 years of career. It's an honor, ladies and gentlemen, to have with us Dr. Durgaprasad Reddy. Can I hear a big round of applause? Please welcome him.
I'm audible? Yep. This is a cardiac transplant topic where I'm going to talk completely about medical. I think someone who's non-medical kindly edges. And cardiac transplant for a surgeon, it's a very small thing. Surgeon plays a very minimal role in cardiac transplant. Actually, he does the stitching, but the rest of the team plays a major role in cardiac transplant. I think it's a great teamwork where a lot of technicians, the doctors, the assistants, everything, they play a major role in cardiac transplant. So thanks, Times, and thanks, Shabi, to introduce me, to bring us here to show what Vydehi does. And we have done a great job. From 2004, we are at Vydehi. We have done a great work. And so we have done 12 transplants, and one died due to lung infection. We didn't get any transplants for next 1 or 2 years. Once the patient dies, they stop coming to us for transplant. Then eventually we started, we realized what we did and other things, and then everything went on well. So now we are following up all this transplant, and they're really doing very well. It's a lot of surgeons say, you're doing a transplant, you're going from one disease to another problem. It's not so. When you closely monitor these patients, I think they do better. So I shouldn't be talking about transplant without the history. The first transplant, most of them knows, it's Christian Barnard. We take some negative points from him, actually. He's a pioneer in transplant, but he committed the first surgery, what he did, the patient lived for 18 days, and he said 80% success rate. The press came heavily on him. So we be careful now. We don't say it's 80%, 40%, 50%. We see, leave it to God. Healing is in God's hand. We do the transplant, let the God heal. That's what we say now. And of course, Adrian Kantrowitz, he's a pediatric transplant, first in US. Norman Shumway, adult transplant in US. And of course, Dr. Venugopal, he was the director in AIMS. He did our first successful transplant. The first transplant was done by PK Sen, but the patient lived for 3 years. The successful transplant was done by Dr. Venugopal, which is, after 25 years or 27 years after Christian Barnard we did. It's not because our surgeons are not competent or we don't have the technology. The reason why it took is the bill was not passing in the parliament. That is what the main issue. The bill, the donor, it's a lot of stigma, how to donate. The bill was not passing. So once the bill cleared, they were able to do it in 2 months. The bill passed in Parliament, the transplant got it done in AIMS. Dr. Venugopal headed the transplant. It was done within 2 months, they were able to do that. So I'm going to talk about indications, systolic heart failure, where the left ventricular ejection fraction is less than 25 or 30%. Ischemic heart disease with intractable angina, where the patient is having this very limited patients we see intractable angina, because whenever the muscles are dead, there won't be much of angina. So again, intractable arrhythmias, dilated cardiomyopathy or hypertrophic cardiomyopathy. Congenital heart disease is also well coming up for transplants now, but we need to see whether the pulmonary artery pressures are at lower level. But of course, even the pulmonary artery pressures are very high, we can still do a heart and lung transplant. And cardiac tumor confined to the myocardium. So when you talk about absolute contraindication, they say age above 70 years, you're not supposed to transplant. There are some instances where a lot of people who are healthy, they need a transplant. They want to have life for 5 years, 6 years. Even at 80s, transplants have been done. So I think age shouldn't be the criteria. It depends on how well he wants to cope up with his life. And again, I was talking about this fixed pulmonary hypertension. That is pulmonary vascular resistance, that is the lung pressure, should be not more than 5 Wood units, or a transpulmonary gradient not more than 15 millimeters of mercury. So suppose it's more, you always subject the patient or a child to a heart and lung transplant. You can't do only heart transplant and come out because the child won't survive. So again, other illnesses which limits the survival, we can't do, like HIV, AIDS, SLE. But still, HIV healthy, now HIV is well managed. I think a patient wants a transplant, we should go ahead and do it. I think we shouldn't make sure saying to the patient that HIV means we can't do a transplant. It's an indication which has been formulated by someone, you know. I think we need to look further. If HIV is really healthy, is being well managed, I think why not? Why not give a chance to him to survive? Oops. Yeah, these are a few tests. I'm not going to the details. So you need to do all the tests to see whether this patient doesn't have infection. Because what we do in transplant is we put a lot of immunosuppressive drugs that will produce a lot of infection. Make sure the patient doesn't have some kind of infection before itself, so that he'll get into more issues when we post-transplant. So we do all this test, and we get all the cultures, make sure he's infection-free and other things. So when it comes to investigation, so the basic investigation, when a patient comes to you, he'll be having a low EF, you get an echo shows 25% EF, then diagnose it there itself. You see whether it's dilated cardiomyopathy or ischemic cardiomyopathy. If it's ischemic cardiomyopathy, if it's more than 40 years, subject him for an angiogram. If there are blocks, then check for his viability of the myocardium. Viability can be checked by PET scan, thallium, MRI. There are so many ways to see the viability of the scan. Suppose the muscle is viable, only then you can do a bypass surgery or a revascular surgery. Suppose the myocardium is not viable, that means the muscle is dead, then you subject the patient straight away to transplant. Cardiomyopathy, like dilated cardiomyopathy, you straight away say patient to go for transplant. The more important thing is the coronary angiogram test, what they were saying is not required for a transplant patient, it's the recipient. What we have to do is do a carotid Doppler, peripheral artery Dopplers, so that you make sure the patient doesn't have any other peripheral diseases. But that will create more issues, because anyway the heart is going, you know, we're going to remove, suppose the patient has got a coronary block, we're going to remove that heart, but patient is going to have a carotid block or a peripheral artery block, make sure he doesn't have all these things. And most important thing, what I say is, we need to do a psychiatry counseling. That's a very important thing, because most of these patients, you know, we see in movies, you know, when transplant, they jump around, dance around, they have emotional contacts, all these things doesn't happen here. Because that's why even the Jeevan Sarthike, our local Karnataka transplant organizing team, they don't make sure they don't reveal the identity of the donor. So psychiatry screening is very important here. And donor selection. Donor selection also is very important. They say always the age of the donor should be less than 55 years. But still, there are a lot of instances in Chennai. Dr. Bala, he's put a Russian child who is 14 years child, he's put a heart of 70 years old. The donor was 70 years. It worked well. He's very healthy. The heart doesn't have any issue. The valves are normal. The myocardium is good. The angiogram showed no coronary blockades. So in that case, why not put it? Anyway, see, the 70% survival for this transplants are going to be only, 5-year survival is only 70% or 60%. So why not give a heart to them? So again, a few things I like to say. Never take a heart which has had a prolonged cardiac arrest, where the patients are subjected for a transplant, keep on massaging, there's a prolonged cardiac arrest in the ICU, never utilize, because there may be some amount of injury to the myocardium when they compress the chest and other things. Then prolonged severe hypotension. And because what happens when there is a prolonged severe hypotension, the coronary perfusion also will get depleted. So never get into where there's a prolonged cardiac arrest, prolonged severe hypotension, any cardiac disease. Always check the donor heart for free of cardiac disease. Intracardiac drug, I've seen so many ICUs when the patient arrests waiting for a transplant, they inject adrenal injection into the heart. Please never injure the myocardium, because that heart is going to be a waste. So these are the things what I like to say, the doctors who are being in the ICU treating, so never inject any injection into the cardiac muscle. Then again, severe chest trauma with evidence of cardiac injury, septicemia, extracerebral malignancy, positive serologies for HIV, hepatitis, and hepatitis C. Never use a heart. Donor should not have HIV, hepatitis B, or hepatitis C. That's going to infect this patient. But a recipient, I still feel that we can use a heart. Then inotropic supports. That means where the supports have been very high, which is supporting the heart to kick. So what we do is, these are the tests we do, like laboratory test, echocardiogram makes a very important role, even pulmonary artery catheter evaluation. If you're going to do a congenital heart disease transplant, always do a pulmonary cath. In selected cases, we do coronary angiograms. If the patient is more than 40 years, and definitely we need to do a coronary angiogram, make sure the coronaries are not blocked. How we conduct this transplant is, once the patient has been branded that is cardiac failure, cannot be failure of all medical management, then we register this patient in Government Transplant Committee. What we call it in Karnataka is Jeevana Sarthake, and there's also Noto and Soto, which is linked with Karnataka. And two teams we have. One is an organ procurement team, and other is a transplantation team. The organ procurement team will consist of a surgeon, a perfusionist, assisting nurse, and anesthetist, and also a cardiologist. All of them go to the center, or if it's in our center, we always go to the theater where the patient is shifted to the theater. These people, these doctors, this team of organ procurement team goes to the center, and they should make preparation they should also carry the ice box with wheels, and also a lot of ice slush is required. And once they reach, organ procurement team goes to the respective hospital, they'll have to go and evaluate. Once it's evaluated, means the patient has to be declared brain dead. Only then we can take the organ, especially the heart. The brain dead has to be declared by the doctor who's treating there, medical superintendent, a neurosurgeon, a neurologist, and even the procurement team doctor who goes from our team also should declare brain dead. Then they'll have to proceed with the donor heart harvesting. The heart is the one which is removed at the end, because whenever there's a donor, we remove all the organs, like they remove liver, pancreas, eye, kidney, everything is removed for the patients. So, but the heart is the one which is removed at the end, because it has to perfuse all the organs. Whereas in a multiple organ transplantation, heart is the one that has to be replaced first before transplanting the kidney and the liver, if the same patient has got the same disease. So after harvesting the heart is placed in a cover containing HTK. HTK is a solution which preserves the heart. And then the cover is placed in a bag containing a cold saline, and then it's placed in a third bag containing 3 bags we have, which contain, I'll show the video how it's been done. And the arrangements are made for a green corridor by the police. So the police has been very kind. They give every level, they give an inspector, and also a traffic jeep follows the ambulance. They completely give a green corridor so that there is no hassles. Recently, we were able to get a heart from Mysore in 1.5 hours. So we were able to successfully do the transplant, and the patient is already discharged. This was done not even 20 days back. And as soon as the donor heart arrives at the hospital, it's again flushed with HTK cardioplegia. That means we give a solution into the aorta, and that in turn gets into the coronary arteries. So that will go and protect the heart, HTK. This HTK will always work for 90 minutes. So every 90 minutes, you need to keep flushing with HTK cardioplegia. That is how it is done. So this is a pictorial presentation, how a donor cardiectomy is done. So what we do is we incise just below the innominate artery there, and then at the confluence of the pulmonary artery, we incise the superior vena. This is the superior vena cava, just at the innominate SVC junction. We make sure the SVC is kept lengthy, and also here at the diaphragm level you incise. The diaphragm comes like this. We incise at the diaphragm level so that always the IVC and the SVC is you always take extra structures so that whatever it is, we can really modify it there. Okay. So this is donor cardiectomy. I mean, First, we divide the SVC. We make sure the aorta and pulmonary arteries are gone around. We separate the aorta and the pulmonary. It's always stuck to each other. We separate it, loop it. Then we prepare this donor heart storage with the HTK solution. We have steel jars. Also, plastic cover is put. Cole's HTK solution this is. We fill the jar with the cold HTK solution. Then we also cannulate the root. Can you see this? The root is, that's an aortic root, which is cannulated with the cardioplegia cannula. We need to flush the heart, with the HTK solution. Once the other organ perfusion is being done and removed, then we come to this area. What we do is we clamp the superior vena cava. Once the superior vena cava is clamped, we incise the, we put a vent into the inferior vena cava and into the right superior pulmonary vein. That means we drain out all the blood by putting the vent. Make sure the heart is completely empty without blood. And a lot of ice has been placed on the heart. So these are the structures I've already shown that. Then we proceed with the cardectomy. What we do is, first is the pulmonary vein dissection. We take as much as possible of the pulmonary veins. If there's a lung transplant too, then make sure you take, don't take too much of pulmonary veins. You take which is sufficient for you. Then the next is the division of aorta and the pulmonary artery, then division of superior vena cava and inferior vena cava. And this inspection of the heart donor, heart is very important because make sure the heart is not diseased, doesn't have a patent foramen ovale and other things. And place this heart, pack it. This is how we sterile pack this heart. Put it in another bin and then pack it with another plastic cover. And ready for transport now. So we put it in the ice box, which is with full of slush, ice slush, and then ready for transport. This is a standard which is done everywhere. Once the heart moves to the center where the donor heart is there, then we don't touch the packet. We use the artery forceps, pull up all the things. Never use your hand. We always use our artery forceps. Cut it open. Heart is soaked in the HTK solution. Can you see that? Heart is soaked in the HTK solution. We remove the heart. And then we need to prepare the heart. We need to make the cuff because the heart is come with the pulmonary veins. So we need to make a LA cuff is to be made. So we cut open all the pulmonary veins. We connect each other and make a cuff. Any excess cuff is there, we excise it. Can you see that? We cut open the pulmonary vein. See, this is a LA cuff. The excess tissue has been trimmed off. The excess tissue, we trim it. So there are two techniques of implantation techniques. One is biatrial and bicable. What our team does is What we do is a biatrial technique. In a biatrial technique, what happens is we make sure, this is how the area looks. Yeah. So what we do is, first is left atrial anastomosis and then other things. I'll show you in the video. I don't want to waste time in talking on this. We come from the left. First is the left atrial anastomosis. We perform the cardectomy in the similar fashion. We always excise the pulmonary veins, aorta, pulmonary artery. Everything is excised. This is how the cardectomy. It's a famous saying from Dunton Cooley. You know, the diagrams don't bleed. What you saw in the diagrams don't bleed, but here a lot of bleeding will be there. First is the LA anastomosis, what we do. LA of the donor to the recipient. We anastomose in a very closed. We don't make sure the stitches are approximately and 1 millimeter or 2 millimeter distance. We don't use heavy stitches like 2 or 3 O. We use actually 4 O. LA to LA is anastomosed. Make sure we also inject water to see there is no leak posteriorly to the LA. Once the LA is anastomosis, left atrium is anastomosed, we anastomose the pulmonary artery to the pulmonary artery. That is donor to the recipient anastomosis done. It is end-to-end anastomosis. We use 5-0 proline because that produces not, the holes don't bleed. 5-0 is a very thin stitch. 5-0 proline is a very thin stick. After pulmonary artery, aorta is anastomosed, again end-to-end. Aorta is also used with the 4-0 proline because aorta is a thicker structure than the pulmonary artery. Once the aorta has been anastomosed, we go into the inferior vena cava. A lot of times we make sure the inferior vena cava is more in the donor recipient heart. Can you see the cannula here? This is a heart-lung machine where the cannula is taking all the blood into the machine and getting oxygen and coming back. What we call as cardiopulmonary bypass. The patient is on cardiopulmonary bypass where the heart can be, without heart, the patient is functioning with the machine. After the IVC anastomosis, we anastomose with the superior vena cava. This also, we use a very thin stitch. We use 6-0 because superior vena cava is a very thin structure. We use a very 6-0 stitch, continuous stitch. Make sure there's no leak. A lot of mismatch will be there because always the donor heart will be very small. The recipient heart will be very big because already dilated structures. So we need to mismatch. Once the cross clamp is released, the heart starts beating. This is how our heart starts beating. So this is how the hemodynamics of the heart. You can see two P waves sometimes is seen because there's two LAs there. The left atrium of the donor and the recipient both are there. That's why you may find sometimes two bifid P waves are available. So once this is done, we suppress immunosuppressive therapy is being done. There is calcineurin inhibitors we give with cyclosporin and tacrolimus. Nowadays, we don't use cyclosporins. We use tacrolimus mostly, and corticosteroids, antiproliferative agents like MMF, because all these things will suppress the immune system so that the heart doesn't reject. So these are the pre and intraoperative immunosuppressive therapy. So we use MMF, basiliximab, methylprednisolone, tacrolimus, and we also give cordon and isoprenin for 4 days. So most important thing is we need to look for the complication very closely. Heart transplant is a very simple surgery actually. The average cardiac surgeon will be able to do a transplant. But the most important thing is how they manage. I think my team is very good. They're sitting there. I think I congratulate Satya and Dr. Vikas who are sitting there. They are the best people to take care of this transplant. And they've been very, very closely monitoring these patients. So what we see in acute rejection is subtle symptoms. What we have is unexplained fever, tachycardia, fatigue, shortness of breath, joint pain, and sometimes patient is a little delirious. So we do an echo. Echo shows a myocardial edema or a decreased left ventricular contractility. And we subject the patient for an endomyocardial biopsy. That means we take the patient to cath lab. We take the through the cath lab, we take small portion of muscle and test it in the lab. So we have grade 0 to grade 3. Grade 3 and 2, moderate to severe, means we need to have a treatment should be varying. So whenever the patient has been subject as grade 2 and grade 3, sorry, it's a printout mistake, 2 and 3, there is no grade 4 here in this one. Once there is grade 2 and grade 3 rejection, so specific anti-rejection therapy is initiated. We increase the dose of methylprednisolone for 1,000 to 1,000 milligram to 1,500 milligram in adults. We give it for IV for 2 weeks. In children, we give 15 milligram per kg. And if there is no response or there is no hemodynamic compromise, we also give ATG, which is antithymocyte globulin, or monoclonal antibodies, 5 or 10 days. This acts on T3 lymphocytes. If it's inactive, then we always subject these patients for a retransplant. So infection is very important on a transplant patient. We should give a lot of advice to them not to be, they have to be very, very careful not to get into infection because the immune systems are suppressed. So the early infection occurs within first month of transplantation. It's mostly nosocomial, that is by a Staphylococcus species or gram-negative organism. Late infections are 2 to 5 months, which is mostly opportunistic infections like cytomegalovirus, pneumocystis, fungal pathogens, and other things. And the most common infection for heart transplant is lung. Lung is the most important thing. You need to be very protected, and followed by blood, urine, GI tract, and sternal wounds. Early infection, as I said, first month is pneumonia, mediastinitis, sternal wound infection, catheter-associated bacteremia, UTI, and mucocutaneous infections. Late infections, you have plenty of infections. You need to look for all these infections. Make sure they don't get into this infection. Make sure they get appropriate antibiotics and things. And whenever you find the patient is getting an infection, you also reduce your suppressant, like steroids have to be reduced. These are the things we follow. We reduce the steroids. And most important thing is chronic complication. This is where we need to look in. Patient after 3 years or something, you get cardiac allograft vasculopathy. That means the coronary arteries get blocked. Normal coronaries, what we see is the eccentric blocks, like atherosclerosis blockades are eccentric, whereas in a transplant heart, can you see this is a circumferential luminal narrowing? So patient will have, again, a chest pain and things. This renal dysfunction, all these things are avoided now because we don't use cyclosporin nowadays. We use tacrolimus. All hypertension, everything has been avoided. Malignancies have been noted in few patients. So other chronic complications are osteoporosis, obesity, cachexia. You know, they behave very differently. Some patients have obesity, some patients are really emaciated, a lot of gastrointestinal complications. So we need to be very careful when a transplanted patient is being done. So close monitoring is very important. So cardiac retransplantation is done when there is early graft failure, allograft coronary artery disease, as I showed, and refractory acute rejection. So this is the discharge medications we put, and teamwork works. That's what I believe, and this is what is. Thank you.
I now request Mamta Nalareddy to please come up on stage and present a memento to Dr. Durgaprasad Reddy. Thank you, Doctor, for gracing this occasion with your presence.